Hi there, my name's Ryan. I am an ALS paramedic in Victoria. Within this video, I will be discussing tension pneumothorax, pleural wall decompression, and I will demonstrate a finger thoracostomy. We begin with a quick refresher of pneumothorax. Simply, a pneumothorax is a collapse of the lung when air enters the pleural space. We can see in the picture here that there is a small gap between the visceral and parietal pleura, normally filled with a thin film of liquid. This pleural space is a potential space for air to enter and collapse the lung on that side of the chest. When the lung collapses, it impedes optimal ventilation for that lung, meaning there is a decrease in the ability for oxygen to get into the bloodstream and carbon dioxide to be exhaled. There are multiple ways to develop a pneumothorax, including penetrating and blunt chest trauma, barotrauma through positive pressure ventilation, and in some cases, people can develop a pneumothorax through autoinflation because of obstructive disorders. In a lot of these pneumothorax cases, from a pre-hospital perspective, there will be no need to intervene beyond the ability to recognize a pneumothorax and prepare in case of deterioration. In some cases of pneumothorax, they can evolve into a life-threatening disorder due to the buildup of air within the pleural space. Increasing air within this pleural space without the ability to be released causes an increase in the intrathoracic pressure. This increased pressure still worsens the ability for the lung to expand, furthering the ventilation issues, but with sufficient rise in intrathoracic pressure, it can cause collapse of the naturally low-pressure venous blood vessels, the right atrium and right ventricle. This reduction in venous return results in reduced cardiac output. Reduced cardiac output decreases vital organ perfusion and can ultimately lead to patient death. From the trauma perspective, there are two main methods of developing tension physiology. In the patient with an open pneumothorax, the main cause for concern is the sucking chest wound. This is when there is a wound to the chest wall, typically greater than 2/3 the size of the trachea, that acts as a one-way valve, meaning it allows the passage of atmospheric air into the pleural space but prevents its ability to escape. The manner in which this occurs is when the diaphragm contracts and moves down, it increases the volume of the chest and creates a negative pressure within the chest, and air moves into the lungs, and in this case, atmospheric air enters the pleural space. When the diaphragm relaxes, the volume decreases, meaning higher pressure, and air leaves the lungs. But the wound acting as a one-way valve prevents air leaving the pleural space, resulting in tension physiology. For the closed pneumothorax, it is due to damage to the lung parenchyma that results in increasing air within the pleural space. This lung damage could come from fractured ribs that penetrate the lung parenchyma and allow air to escape out of the lungs and into the pleural space with each breath. Of significant importance is the patient that is being ventilated due to air being forced in with each breath and typically devices being utilized to splint open alveoli, such as a PEEP valve. As air enters the lung and escapes into the pleural space, it slowly increases the intrathoracic pressure, preventing full expansion of the lungs and impeding venous return. This leads into managing the tension physiology. If tension pneumothorax is recognized, it should be promptly decompressed to improve ventilation and perfusion. The way this is done is by creating an escape for the air. This can be done by a simple surgical procedure called a finger thoracostomy. The finger thoracostomy, while its indications will be service-specific, as a general rule it would be utilized in cases where tension physiology is apparent. This typically means it will be employed in traumatic cardiac arrests where there has been chest wall injury or likely chest wall injury, and in episodes of pneumothorax where there is tension physiology developing or suspected. The finger thoracostomy is an extremely invasive procedure involving intentionally incising and penetrating the chest wall with sharp and blunt instruments. With this in mind, it should not be performed on patients that are conscious. The equipment needed to perform a finger thoracostomy are again service specific, but across most services they will have the same general equipment. We will need appropriate PPE for the paramedic, being gloves, mask and eye protection, some sort of sterile wipe to clean the chest wall, a scalpel and typically curved forceps. For the post-procedure, a sterile cover should be placed over the top. Once we have identified that our patient requires a finger thoracostomy and we have our equipment out, we need to begin with identifying where we are going to cut. Aim is the fourth intercostal space, that is to say, between the fourth and fifth rib. To aid in ensuring we are incising the right area is to landmark our area of safety. It is surrounded by some key anatomical markers, being surrounded by the base of the axilla, the lateral aspect of the pectoralis major, the anterior aspect of the latissimus dorsi, and the line of the nipple. This area here is the area or triangle of safety. We can also employ the humerus length to help in correctly identifying the incision site. Measuring half the humerus length and then pushing into the chest wall should put you within the triangle of safety. In extreme circumstances where you aren't 100% sure of the correct intercostal space, aiming a space higher reduces the risk of damaging the diaphragm and abdominal organs, particularly the liver, which sits so superiorly within the abdominal cavity. We have palpated and we have our landmark marked. We can use our swab to make the area as sterile as possible. We take our scalpel and we are cutting through the skin and subcutaneous layer. Cutting should be parallel with the ribs to expose the intercostal muscles underneath. We then use our finger to push and palpate the intercostal muscles, while we use our curved forceps to push through the intercostal muscles themselves into the pleural space. This may require some force. Once we have poked through, we can open and close our forceps before putting our finger into the hole we've created to perform a finger sweep into the pleural space. Procedure is successful by feeling air releasing from the thoracostomy hole. This will be supported by a change in vital signs trends. The patient's shock index will decrease by increasing blood pressure or decrease in heart rate. The patient's ventilation will improve by showing an increase in SpO2 and end-tidal CO2 thanks to returning venous circulation to the lungs. Covering the wound with a sterile dressing is recommended post-procedure. Services will have specific dressings to be utilized. Within Ambulance Victoria, a stoma bag dressing is to be placed over the incision. Other services utilize a clear 3-sided dressing to allow continued draining but ease of access to re-decompress if needed. Some potential problems when completing the procedure is air not being released, which can be prevented by ensuring we are in the right landmark and sufficiently poked through the intercostal muscles. A large amount of blood could be released from a hemothorax, which is difficult to prevent but can be managed by appropriate volume replacement, or neurovascular bundle damage, which sits just below each rib, which can be prevented by pushing through above each rib. Benefits of utilizing the finger thoracostomy is that it is completed in the lateral aspect of the chest wall, which is thinner than that of the second intercostal space at the midclavicular line. It is superior to needle decompression, being that the thoracostomy is not limited by the needle length impacting getting into the pleural space, and utilizing the finger provides additional sensory feedback informing paramedics when they are in the pleural space. Thoracostomies can also be re-decompressed by performing a finger re-sweep compared to the needle decompression, which requires another needle to be placed. The downsides to completing this procedure is that it is more time consuming to perform compared to the needle decompression, and using the finger puts additional risk on the paramedic Thank you for watching my video.